This video will demonstrate the step-by-step insertion of the Palindrome Precision Chronic Catheter and the MAHURKARTM 14.5 French Chronic Carbothane Catheter via the right internal jugular vein. The Palindrome Precision Chronic Catheter will be used for the purpose of this instructional video. The insertion principles, supplies needed, and techniques demonstrated are the same for both the Palindrome Precision Chronic Catheter and the MAHURKARTM 14.5 French Chronic Carbothane Catheter. However, each of these catheters is packaged with a tunneling stylet that differs slightly in design. Therefore, the specific step that involves attaching the catheter to the tunneler will be demonstrated separately for both the Palindrome Precision Chronic Catheter and the MAHURKARTM 14.5 French Chronic Carbothane Catheter in this video. Other than having different tunnelers, the insertion steps are identical for both catheters. The Palindrome Precision Chronic Catheter offers several unique features, including a symmetric tip design with precision tip technology, laser-cut side slots, and a compact functional tip that allows for increased visualization on fluoroscopy and X-ray, more flexibility to accommodate varying right atrium sizes, optimal flow performance post-insertion with minimal recirculation. The unique symmetric tip of the Palindrome Precision Chronic Catheter minimizes recirculation not only in forward flow, as most catheters are designed to do, but it also provides minimal recirculation rates when the lines are reversed. Reversing dialysis lines is a common practice in dialysis therapy and is often necessary to restore catheter function. If a catheter is occluded or clotted, reversing the lines is often the only option besides replacing the catheter to restore adequate flow and dialysis treatment for the patient. The Palindrome Precision Chronic Catheter also features laser-cut side slots, which are designed to reduce the likelihood of clots forming because they have smooth edges and wide openings. The wide openings allow blood to flow into and through the open side slots during treatment, which may further reduce the likelihood of clotting to occur. Good catheter outcomes post-insertion may depend upon proper catheter positioning during initial placement. Improper positioning of the catheter tip during initial placement can result in insertion complications, poor catheter performance, reduced blood flow rates, and long-term complications including catheter dysfunction. The unique precision tip technology incorporated into the symmetric tip design of the Palindrome Precision Catheter allows for increased visualization of the catheter tip on fluoroscopy and X-ray during and post-insertion. The Palindrome Precision Chronic Catheter and the MAHURKARTM 14.5 French Chronic Carbothane Catheter are both 14.5 French, dual-lumen, high-flow cuffed catheters made of kink-resistant carbothane material. The catheter extensions are made of silicone with Ultim adapters for added durability to extend the life of the catheter. The Palindrome Precision Chronic Catheter and the MAHURKARTM Chronic Carbothane Catheter are ideally placed in the right atrium via the right internal jugular vein. If placement through the right internal jugular vein is not viable, the catheters can also be placed in the external jugular, subclavian, femoral, or saphenous veins as last resorts. The right internal jugular vein is recommended by the Kidney Disease Outcome Quality Initiative guidelines if it is available as an insertion site. Items required for this insertion and included in the standard kit are 1 Palindrome Precision Chronic Catheter or 1 MAHURKARTM Chronic Carbothane Catheter. Both are available in multiple insertion lengths, including 19 centimeters, 23 centimeters, 28 centimeters and 33 centimeters as measured from tip to hub of the catheter. The Palindrome Precision Chronic Catheter is also available in a 44 centimeter and 55 centimeter femoral length. The Palindrome Precision Chronic Catheter and the MAHURKARTM 14.5 French Chronic Catheter are available in a variety of sport pack and kit configurations depending upon the clinician's needs. Each catheter configuration includes 1 valved pull-apart safety sheath, and to accommodate over-the-wire or sheathless insertion techniques, 2 TAL VenaTrack over-the-wire insertion stylets are available if desired. Both options are available to accommodate the preferred insertion technique. The valved pull-apart sheath and the TAL VenaTrack insertion stylets are both designed to reduce the risk for air embolism and blood loss during catheter insertion procedures. Also included in the standard kit are one 18-gauge introducer needle, one 0.038-inch by 70 cm J straight guide wire, one 12 French tissue dilator, one 12 cc lure lock syringe, two sealing caps, one number 11 blade scalpel, two Telfa island dressings, four cotton gauze sponges, and one bifurcated tunneler for the Palindrome Precision Chronic Catheter or a standard one-time tunneler for the MAHURKARTM Chronic Carbothane Catheter. The unique bifurcated tunneler for the Palindrome Precision Chronic Catheter is designed to ensure secure catheter placement, with a unique sheath and node system that greatly reduces the risk of catheter detachment from the tunneler when tunneling in the subcutaneous tissue. The tunneler that is supplied with the MAHURKARTM 14.5 French chronic catheter is slightly different in design, but also provides a low-profile sheath to minimize the tunnel tract size, and it is also malleable for user customization. Additionally, you will need prepping and draping materials, skin anesthesia, clamps, gauze and dressing materials, and a method for stabilizing the catheter such as sutures or a catheter securement device. You will also need sterile heparinized saline for flushing the catheter. Some physicians prefer to use a micropuncture kit for insertion rather than the 18-gauge introducer needle. You will also need to have access to fluoroscopy, ultrasound, or X-ray to confirm placement of the guide wire and catheter. When beginning the procedure, provide a sterile operative field using sterile drapes, instruments, and accessories. Perform a surgical scrub and don appropriate surgical attire. Prep the patient according to institutional protocol and isolate the access site with sterile drapes. For jugular insertion, turn the patient's head slightly to the side to expose the insertion site. At this point, you can use landmarks to locate the internal jugular vein, but the true standard of care is to utilize ultrasound to visualize the jugular vein. This dramatically decreases the risk of inadvertently puncturing the carotid artery. Once you have identified the jugular vein or alternate insertion site, administer local anesthetic to the skin and underlying tissue at the venotomy site. Following this step, there are two generally accepted methods for accessing the internal jugular vein, either utilizing an 18-gauge introducer needle or using a standard micropuncture kit. The following section will demonstrate the use of the 18-gauge introducer needle. Flush the 18-gauge introducer needle with sterile heparinized saline. Insert the needle and advance it into the vein in the direction of blood flow. After inserting the needle through the venotomy site, attach a 6 cc syringe. While drawing back on the syringe, aspirate a small amount of blood. Look for a dark flash of blood to confirm the needle has entered the vein. Once you see venous blood flash, disconnect the syringe from the needle and promptly insert the flexible J end of the guide wire through the introducer needle. Failure to insert the wire promptly may lead to blood loss or air entrance through the needle. Continue to advance the wire into the vein. The length of wire inserted will be determined by the size of the patient. Be careful to avoid contacting the heart muscle with the guide wire, as cardiac arrhythmias can occur. Once the guide wire is in place, withdraw the introducer needle, leaving the guide wire in the vein. Be sure to stabilize the guide wire to prevent further advancement or retraction. Next, identify the tunnel tract. Visualize your tunnel in a gentle wide arc, 5 to 6 centimeters distal from the venotomy site. Mark your exit site. Now move upwards from the exit site a minimum of 2 centimeters towards your venotomy site. Note, this is where your cuff will be. With a measuring tape, measure from the cuff site back to the venotomy site, and then down the mid-clavicular line to the third intercostal space approximating the mid-right atrium. This measurement will give you an estimate of the tip to cuff measurement or insertion length of the catheter. Flush the catheter with sterile heparinized saline and clamp the extensions immediately to decrease the risk of air embolus during insertion. Keep the catheter clamped at all times when not attached to a syringe to prevent air from entering the catheter. Whether using the 18-gauge introducer needle or micropuncture kit method of insertion, you will use the same procedure to create the tunnel tract. Identify the tunnel tract. Mark the exit site. Begin by administering local anesthetic to the tunnel tract and underlying tissue. Utilizing a number 11 blade scalpel, make a 1/2 to 1 centimeter incision adjacent to the guide wire at the venotomy site. This creates the insertion site and prevents the formation of a dermal bridge, which may snag or inhibit passage of the catheter during insertion. Make a second incision parallel to the first at the exit site. Make the incision long enough to accommodate the cuff, approximately 1 centimeter. Blunt dissection may be used to create the subcutaneous tunnel starting at the exit site incision and working toward the venotomy site. This can ease the catheter's passage through the tunnel. Now attach the primed and clamped catheter to the tines of the tunneling stylet until the catheter tip meets the base of the tines. Slide the plastic sheath completely over the connection until it stops. If desired, bend the tunneler into a wide arc to facilitate creation of a curved tunnel. Be sure the guide wire is secure to prevent movement during the tunneling procedure. Insert the tunneler into the exit site and create a short subcutaneous tunnel emerging at the insertion site. Pull the catheter through the tissue as the tunnel is created, being sure to emerge adjacent to the venotomy site. Ensure the catheter passes through the tunnel to the primary insertion site. Pull the cuff into the tunnel, leaving it a minimum of 2 centimeters from the exit site. Remove the catheter carefully from the tunneling stylet. First, slide the sheath of the tunneler back. Next, grasp the tip of the catheter and gently pull the catheter from the tunneling stylet. Discard the tunneler. If using the micropuncture kit, withdraw the 5 French coaxial dilator, leaving the guide wire in the vein. This is not necessary when using the 18-gauge introducer needle. If inserting the MAHURKARTM 14.5 French chronic catheter, the tunneler attaches to the venous lumen of the catheter. Make sure the lumen meets the base of the tunneler tines. Slide the plastic sheath completely over the connection until it stops. If desired, bend the tunneler into a wide arc to facilitate creation of a curved tunnel. Be sure the guide wire is secure to prevent movement during the tunneling procedure. Insert the tunneler into the exit site and create a short subcutaneous tunnel emerging at the insertion site. Pull the catheter through the tissue as the tunnel is created, being sure to emerge adjacent to the venotomy site. Ensure the catheter passes through the tunnel to the primary insertion site. Pull the cuff into the tunnel, leaving it a minimum of 2 centimeters from the exit site. Remove the catheter carefully from the tunneling stylet. First, slide the sheath of the tunneler back. Next, grasp the tip of the catheter and gently pull the catheter from the tunneling stylet. Discard the tunneler. If using a micropuncture kit, withdraw the 5 French coaxial dilator, leaving the guide wire in the vein. This is not necessary when using the 18-gauge introducer needle. Now thread the 12 French dilator over the end of the guide wire. Advance the dilator into the vein only as far as necessary using a rotating motion to assist passage through the tissue. Be sure to hold the guide wire in place without advancing it further into the vessel. Once dilation is complete, remove and discard the dilator. Repeat this step with the 14 French dilator if desired. The optional towel Venatrack over-the-wire insertion stylets were designed to facilitate over-the-wire or sheathless insertions. Flush the towel Venatrack over-the-wire insertion stylets with sterile saline prior to use. Wetting the outer surfaces of the stylets as well may facilitate advancement into the catheter. Load the stylets into the catheter. Ensure that the white, flat side of the longer stylet containing the stylet side hole is oriented against the septum of the catheter lumen. Advance the stylets all the way through the catheter and lock the back end of both stylets to the catheter hubs. Be sure the catheter clamps remain open to ensure the stylets are not damaged. Note, if preparing the catheter for tunneling, unlock the stylets and pull distally at least 8 centimeters to facilitate attaching the tunneler. When tunneling is complete, attach the guide wire. Flex the tip of the longer stylet 45 degrees to assist the guide wire exit. Thread the guide wire 1 centimeter into the distal tip of the longer stylet such that it exits the stylet side hole. Continue threading the wire into the distal tip of the adjacent shorter stylet until it is seen emerging from the back end. It is important to wet the wire for ease of advancement. While maintaining control of the guide wire, pinch the catheter stylet forcefully, approximately 2 centimeters from the distal tip. Advance the catheter into the vein while pinching the catheter stylet. Rotate in a clockwise direction to ease advancement. You will feel a resistance and distinctive pop as the catheter passes into the vein. Continue to pinch the catheter forcefully and advance the catheter stylet assembly until the catheter tip is positioned as desired. Use fluoroscopy to view and confirm catheter placement. Holding the catheter in place, gently remove the guide wire and discard. It is important that the guide wire is always removed first before removing either stylet. Next, immediately unlock, remove, and discard each of the 2 Tal-Vena-Trac over-the-wire insertion stylets, being sure to clamp the catheter extensions. Flush the catheter with sterile heparinized saline and clamp the extensions immediately to decrease the risk of air embolus. Keep the catheter clamped at all times while not attached to a syringe to prevent air from entering the catheter. When utilizing the FlowGuard valved pull-apart safety sheath, remove the 16 French dilator from the sheath. Slide the valve over the sheath opening. Insert the dilator through the valve. Lock the dilator in place using the rotating collar. Thread the locked valve sheath assembly over the end of the guide wire. With a rotational motion, advance the assembly into the vein, again holding the guide wire, being sure not to advance the guide wire further into the vessel. While holding the sheath in place, unlock the rotation collar. Gently remove the dilator and guide wire together from the sheath. Discard the dilator and guide wire. Insert and advance the catheter quickly through the valve of the sheath. To prevent kinking the catheter, it may be necessary to advance in small steps by grasping the catheter close to the sheath while inserting. Continue inserting the catheter through the valved sheath and into the vein. After the catheter has been positioned, grasp both ends of the sheath firmly. Crack the sheath in half. Peel the non-valved side of the sheath handle partially away from the catheter. Near the valve, hold the catheter firmly in position and pull the valve off the catheter. Remove the sheath from the patient by holding the catheter in place and pulling the separated sheath tabs away from the entry site simultaneously at a 180-degree angle. The sheath will separate from the catheter, leaving the catheter in the vein. Note, some resistance may be experienced while pulling the valve off the catheter. Use fluoroscopy to view and confirm catheter placement, being sure to position the catheter correctly in the right atrium. Confirm catheter patency and function by aspirating venous blood from both the arterial and venous lumen. A rate of 5 cc per second or more represents good flow. Flush at least 5 cc of sterile normal saline into each lumen to clear the blood. Follow with a heparinized saline lock of 5,000 units per milliliter or according to institutional protocol. Note the priming volumes are printed on the sleeves of each lumen. Clamp the extensions immediately after infusing, utilizing the positive pressure technique. Place a small amount of heparin in each of the sterile injection caps and attach the sterile injection caps to each adapter. Suture the entry site and stabilize the catheter with sutures using the extension wings on the catheter hub or by applying a catheter securement device. Apply a dressing to the catheter insertion and exit sites. Confirm final catheter placement with fluoroscopy.